We're very excited about the prospects for this vaccine candidate because the landscape has changed so dramatically in such a short period of time. We now know fundamentally with clinical data and licensed products that immunotherapy is a reality. When I was in graduate school, 50% of the immunologists in the room would have said it isn't feasible and not a reality. So we now would know categorically those no longer true. We know that, and we also have learned some of the major pitfalls associated with the past vaccine approaches, and we're able to capitalize that and build that into our development plans and try to address them head on in terms of a better quality of antigen that we're trying to attack, inducing CD4 responses as well as CD8 responses, and focusing on more than just a single epitope, trying to induce a broadly reactive polyvalent response to avoid immunoselecting tumor variants that can avoid immune escape. Working with Columbia University's Brain Tumor Center, we have used patient samples, specifically peripheral blood mononuclear cells, and asked a simple question: if we expose these cells ex vivo to our vaccine formulation, do they respond in terms of a CD4 and a CD8 response? In comparison to healthy subjects that are also CMV positive, we see that the patients do in fact respond. Both CD4 and CD8 responses are induced. Quantitatively, they are as strong as what you see with healthy subjects, and critically, qualitatively, they respond in precisely the way we'd want to when we formulate the vaccine with GM-CSF. By that, we induce the CCL3 biomarker identified by the Duke study, as well as interferon gamma, a cytokine that's long been associated with good clinical outcome in cancer. We have additional in vivo data demonstrating that if we immunize mice with our vaccine candidate, we can induce both CD4 and CD8 responses, and qualitatively that they are the right type of response, a pro-inflammatory Th1 type response.